Hello. Good evening, friends. Welcome to all the delegates from the Chalaram Diabetic Institute. And in this symposia, I'm going to invite Dr. Mohan, and he's going to talk case for the pump and the role of the CGMS in the particular type 1 diabetes. Dr. Mohan, please.
Good evening, everybody. So first of all, again, it's a proud privilege to be here in this debate. So the rephrasing would be, it is not all, it should be actually for those who can afford and who can try with it. So this is the topic, continuous continuous and CGMS for all patients of type 1. So I have no conflict of interest. I have taken some slides and it is not company driven. So the debate, we have a friendly debate with us. So I will be boxing hands with Dr. Ganesh Javalikar, a senior doctor, and we have to discuss type 1 and those who are on my MDI versus CGMS plus CSI. So starting with the case, a 7-year-old boy brought with us with acute onset of abdominal pain and vomiting, no past history of medical illness. On body weight examination, he was having dehydration and tachycardia. Obviously, the sugars were high, and he was having diabetic ketoacidosis. And first time he has come and he required insulin therapy and admission. And he was stabilized and then sent back and required basal bolus therapy, a fair dose, 65 units per day, and resumed schooling and required. But finally what happened, he has to come back to the same hospital where I work with 3 weeks later, where he had gone for a picnic. It happens. So he had come with occasional missing the dose, and still he had a recurrent with diabetic ketoacidosis. So the options available at this juncture, patient extended is the MDI plus home-based glucose monitoring. The other options, MDI with real-time CGM, which can help the monitoring part. The multiple daily with flash sensor, which is the about other one. Then the one which I am speaking about is the insulin pump with real-time CGM. So other side, insulin pump plus flash CGM is also there, but this is the one integrated, which is the sensor-operated pump. So insulin is required for life. Make it from this slide because insulin therapy has revolutionized the field of type 1 diabetes, because we had a child brought with almost dying and saved, and now he is now on saved with therapy. We can see the journey of diabetes as far the insulin is concerned. Insulin pumps were discovered 1960 onwards. The size was big enough. Now they have become pocket-sized, and now they are going into the pivotal stage of intelligence technology. So the first commercial hybrid closed-loop system is the Medtronic 6670G. So the intelligence is because the SMBG-based monitoring has been phasing out. We can see that now meal dose calculators are available. Daphne method approximates the carbohydrate counting. And now we have got last 20 years various forms of insulin pumps. Sensor-augmented pump technology has come in a big way, and suspense low glucose also is available. Fully sensor control, Dr. Basu had mentioned about the fully automated pumps, and the double insulin as glucagon pumps also. So sensor also has a large journey like that. Multiple sensing is required. Based on the accuracy, the sensor technology is also improvised. So the consensus document mentions that CSI pump is the most physiological available method currently available. All the guidelines are endorsed in a uniform manner. And as far as I'm concerned, the 2019 ADA also has mentioned that it's category B level of evidence for automatic insulin systems delivery. So CGM similarly has got approval from all societies, ADA, AAC, Endocrine Society, HETD. So all they are telling is that you have to use them appropriate patient in conjunction with diseases. So SMBG is a finger prick method. It requires monitoring. It requires a lot of patience and a lot of motivation. We can see that the pricks will be multiple daily things, and it doesn't stop. So even when you have hypoglycemia, still you have to continue the prick. When you are snacking, still you have to take the prick. So it means that glucose values need not be same stabilized every time. It is a multiple roller coaster ride requiring a lot of insulins. Dawn phenomenon, we know, patient comes with hypoglycemia. We can have 4 pricks and 4 shots. So even more than that as described. Globally, the pump technology is well accepted. And Indian population, the number is growing. The country-wise, only 50 countries are not accepted still. The data is growing, even CGM is used, and you can see that data is very high. And gestational diabetes also on pump also is not new. So insulin dose depends on multiple factors. One thing I have to consider is the stage of puberty. The puberty stage, it requires a lot of hormonal influences, and that period, definitely, insulin has to be given in a tailored dose. And site of injections, very important. We can't monitor every patient every time in a clinic. We can see nutritional intake. Every patient has different nutritional demands. Exercise also different. Daily routine. Any patient with stress, the routine requirement is going up. Results of monitoring definitely need a documentation. And glycated HB, not accurate every time. So intercurrent illnesses in children definitely play a major role because sometimes patients hesitate to intensify therapy. So multiple daily injection cannot adjust for the intra-patient variability. The small fractions are important in children. Starting from 1 year of age, we are seeing that we need multiple small doses. Accurate dosing based on bolus wizard is very good because I have used it, it found very appropriate. Active insulin, this is the smaller fraction available after the last dose. After the last bolus, a small fraction remains. That is actually minimal, and it is called active insulin. That prevents the overdosing of the next insulin. Convenience factor, because the patient has a convenient thing, he can tailor it because he's going for a less of a party, he can adjust it. And the demands are also different. So multiple basals for multiple times can be also adjusted. And snacking, because it is not possible sometimes with MDI to give a snack and a insulin correction. Exercise, definitely children can't be left to sleep in the indoors. They have to go and play. That time, unanticipated exercise can also happen, swimming. So all these can be done, even is safe for waterproof also. Adolescents with type dawn phenomena, I have already told you, patients are virtually unmanageable with MDI. So insulin pumps use only rapid-acting insulins. They have lowest intra-patient variability. They minimize the error due to pharmacodynamic stability, and they are easily produced day in, day out. So you can see that multiple daily insulins can include intermediate-acting insulins, long-acting insulins, rapid-acting. We can see that only the rapid-acting insulin has got the least variability in the insulin action. So my focus is on the sensor-augmented pump. It has got various facets because motivation is one thing, cost is the major thing, and interpretation is also another thing. So healthcare giver has to be properly trained, patient properly selected. I agree that instruction should be given how to adjust also, and parents should be involved as well as the teacher. So definitely our program is definitely there. In Kerala, thankfully, we are doing it. Last 1 year, we have got a Mithai program. It's a comprehensive free therapy method by pump or insulin analogs are provided free of cost. So fallacy of the average. We can see the HbA1c tool alone won't be able to tell the patient's control. We can see that the same A1C can be there in 2 patients. That may not be the same thing for that patient. And we can see that by using 2-week values as per the capture AGP or the 5-day value by the real-time CGP, both show a better results than the HbA1c. But HbA1c calculated by the device actually more efficacy than by the labs. Why it is important? Glucose variability can lead to microcirculatory damage. There is no doubt that even Ganesh sir will agree that oxidative stress is one factor which accumulates with time. So if we are not giving proper correction and proper management, that can lead to early onset of complications. And this is the publication by Naveed Sattar et al. Mentioning that there is a role for a dysfunctional immune response active in type 1 diabetes, which makes it that it is a cardiovascular disease and it is faster than the type 2 diabetic. So the time in range concept from the CGM is definitely improved, and we can see that the time to close the loop is also there because even children having a better results with closed loop delivery systems. CGM device, just to show you that type 1 and type 2 both need to have a the range of 70% between 70 to 180, and the values definitely, as I have shown you, should be kept HbA1c less than 7.5. And those in pregnancy, the target is more stringent. The challenge is definitely absorption delay is one thing, definitely made better by algorithms. The data should be captured properly. The systems, definitely sir will tell about the changing of system, but that can be made simply by a proper technique. And expertise, because patient need not do much. Only the boluses can be given by the patient. The basal can be adjusted. And a better glycemic control and quality of life. Many studies have shown that it is better for the pump therapy. So indications, we know we live in a place where we have no reimbursement technology many places. The motivation is there, important. Supportive family, important. Carbohydrate count nowadays important. But definitely when population is better made out, they have good results. I would like to focus the next talk part into the studies. Effectiveness of sensor-augmented pump is made out by the type 1 in the US by this study. We can see the age group 7 to 12 and 13 to 18 compared. These were divided into two, into SAP at a sensor augmented pump and MDI. We can see that those having the duration also was similar, and these values are always better for the patients with insulin pump. The CSII shows a better A1C than the MDI. These are the meta-analyses published till 2003, showing a uniform data which is showing increase in the results with pump therapy. Because even DCCT trial, which is the major trial supporting the type 1 diabetes and cardiovascular mortality, even those study, 59% of patients were on one time on pump therapy. So that is one thing which the studies are also showing. So cardiovascular risk should not be kept aside when you have a type 1 diabetes. This was made out by the study from the Swedish National Register by Isabel Stenek. So this shows that the follow-up period was also good, large population number. These were also there. So this shows that everywhere the HbA1c was almost similar to that of the patient, but still the time in range concept shows that we can see the hazard risk is definitely improved when we use pump therapy compared to that of the MDI therapy. Even fatal cardiac disease is less, the total mortality is less, and hypoglycemia prevention rate is also better. So significantly reduction in HbA1c is done by the CSII therapy. This was confirmed by another meta-analysis published last 10 years. Severe hypoglycemia, when you switch over to pump therapy, the hypoglycemia is also prevented by 75%. And the type 1 diabetes exchange program shows that the pump therapy and injection, we can see that comparatively, CGM does a major role in controlling the HbA1c than you can see here. So this shows that we need to close the loop and close the loop in an early manner. That is why the Medtronic and other companies have come up with improvisations, and they have actually come up with the tools to calibrate the algorithms. So we know glucose variability is important. The patient has hypoglycemia. The next minute they will stop taking the insulin, and this is definitely bad because intensification of insulin does not happen, then HbA1c will be going up. Finally, they will have a quality of life issues and morbidity, mortality. So dissatisfaction is also important. This study shows that treatment convenience everywhere, CSII is very easy, flexible, understanding is there, and recommendation is also easier. And satisfaction is controlled and continuing with time. So even data is improving with this. So challenges, I agree that a lot of challenges are there. Technology, every rural child may not have the technology access. Supports are also important. Every system may not have a diabetic educator. But definitely by efficacy of self, treatment satisfaction is improved, flexible lifestyle, sleep schedule is improved, and quality of life is there. So type 1 registry is now growing. Just 2 days back, we had a type 1 registry, Foundation of India was there, and this shows that the patient themselves are understanding that pump is better and pump is manageable by them. Reimbursement option, definitely some societies like ESI, that is Employment State Exchange, definitely provide pump. They have given technology. Some banks are providing technology free. Then some reimbursement are done. Definitely, there's a trial period in that, 14 days period where the patient can experience free of cost. That time they can understand whether it's good for them. Then they can go back if they don't like it. It is not like a car which is given a 2,000 rupees note. We need to have technology in a proper manner. A Benz will definitely be better than such cars. So, my friends, technology is not to be underestimated. It is a roller coaster ride with type 1. We can see it is a multiple daily injections. It requires lot of patience, lot of perseverance, lot of flexibility issues are there. Education is important. Carbohydrate counting should be done irrespective of the technology used. Precautions should be done for exercise, illness, and sugar surfacing is still important. Technology makes it easier for them to adopt it. Finally, don't want patients to go for transplantation. That is the ultimate thing. So we, for just 1 minute is left, we have got a lot of experience. Last 4 years, I have worked in 2 centers here. So we can see that Amrita Kochi, where I have worked, we have more than 50 pumps. Mithai project, we have 10 pumps now already last 10 months. And other centers, experience is growing. Now I have to highlight that 2 years back, I heard about one study, indigenous pump project from the Indian Institute of Science, Bangalore. So Mithai project is the flagship project of Kerala. It was launched 1 year back. All patients are provided free of cost pen and free analog insulins. Brittle diabetes are provided pump. Living with diabetes is a training, ongoing process. It's a dedicated helpline number is there. All the patients are given dedicated helpline number. This scientist by name Krishnan Swaminathan published a study in IJEM, which is our Endocrine Society of India study, showing that rural patients given an underprivileged does not mean we have to give them pump. We have to assess them, see the difference before CSII and post CSII. definitely significance is there. Patient number was 16 patients were given. This cannot be done unless motivation is there. Dr. Mala Dharmalingam, my examiner, she also is a part of the study for artificial pancreas system developed by Bangalore IIS. So it is the remote thinking that we are telling CSIA is very costly. We can do it with a proper method. Definitely the time is not late. We can still try the technology. Now we are going to the next level because artificial intelligence is the same device will show both the CGM as well as the real time, the values. And we can see the trials. There are very many trials going on. There is a night hybrid crossover study. There are many studies, the T-Slim study, which will show you. This is the artificial technology from the Dexcom group showing that this is also going to come next one. The last slide, this is the depiction of the journey of a child from the crib to the cradle. You can see that satisfaction is important. Just like the child drew, it's like a pumpkin. So it has both the things divided into it. So nothing is impossible. Unless we think about this, we cannot think more. Thank you very much.